Yes, welcome everybody. I may introduce myself and my co-chair, the wonderful Patricia Lesnick. My name is Hendrik Bruch from Germany, and we are here for the bioMérieux sponsored symposium, which is titled Empowering Change, Tackling Barriers to Implement Rapid Diagnostic Results and Optimize Antibiotic Stewardship, which is quite a demanding topic actually, but I'm almost sure that we will have very nice conversations about this with our two speakers here. I will introduce them shortly. Just a few hints before we start. Actually, there is an app from bioMérieux, which you will find on a QR code, which will be just displayed shortly. The app is named Juicy, and in Juicy you can find literature actually, which is has to do with all the lectures actually we present today. So you can just scan the QR code, download the app, and then you will have access to the literature which is used in the talk. Actually, that's quite a nice idea and gives you the possibility to take something home with you and read in more deepness. So just not to give too many words in advance, I would like to announce Suveer Singh from London, UK, and he will give us a talk on Beyond the Guidelines. I love that title already. Beyond the Guidelines, Addressing Clinicians' Mindlines to Improve Antibiotic Stewardship. So, Suveer, the stage is yours.
Thank you so much.
Very tense.
Thank you to the conveners and to bioMérieux for offering me the opportunity over the next 15 minutes or so just to share some thoughts and hopefully give you some guidance as to a complicated topic, Mindlines at the bedside. We deal with Mindlines, which are our internalized rules of thumb that have been formed based on experience and many other factors, rather than guidelines, and our patients live or die by that. We know the stakes. The AMR burden is super high. If you read the numbers, you'll be told that 1.27 attributable deaths according to that, and it'll increase to almost 2 million attributable deaths to AMR. We also know that we're part of one of a number of different ecosystems that can control antibiotic stewardship or misuse. And indeed, if you think about your patient, your last patient with an MDR, just imagine that that patient has got a 20 to 40% increased chance of dying than if they didn't have an MDR. And that sort of brings to the point something that's more relevant to us, which is our lived experience as opposed to evidence-based meta-analyses, level 1 evidence. We know that over half of our patients on an ICU have a suspected infection or a proven infection. We know that 2/3 of them, sorry, 3/4 of them are on antibiotics. And we also know ICU-acquired infection rates, 22% on average, and mortality differs from where we are. But these are all important facts, but they are not particular to what we are thinking at the time. The UK National Plan to tackle AMR, like many other studies, many other strategies across the world, focus on the behavioral factors and interventions 10 times in this document. So clearly people are aware of it, but where do we take this? So given the stakes, why do smart clinicians still overstart, overdose, overcontinue? This is just examples from our own experience where we had an MDR acinito outbreak in 2008, and it absolutely decimated standard working in the whole hospital, theaters, acute care, having to redeploy people to 3 different places, and so on and so forth. We introduced a microbiologist on our ward rounds who, if you like, the micro police. And they brought down, or we brought down, our DDD rates from 1,800 to 1,200 in the next year. We kept at that level 5 years later. But you can see the creep upwards, so maintaining things is pretty difficult, even once you've started something that's good. I'm going to step back a bit. So philosophically speaking, infection, when does it really start? And actually, when does it stop? We all know the paradigm in this cartoon of exposure, incubation, symptoms, and resolution. But our cure definitions are varied. Cure clinical, microbiological, biomarker-based, treatment-based, antibiotic-free days. There's no standard agreed for cure. And if you've got several standards, and indeed, if that endpoint isn't a defined endpoint by rules, then what I think and what you think might differ in terms of that endpoint. And of course, you would get a negative result from a multi-million pound or euro study. So there is something missing in the sense of how we design really expensive studies, in missing what our Mindlines are and how they influence the outcomes. And these three are just three of the great thinkers of the modern generation. Kahneman, who talked about the idea of heuristics, which are effectively Mindlines, are patterns and how we deal with the decisions that we're confronted with. And you can have a fast thinking system, which will immediately get things right most of the time, but it's subject to bias, and that bias can lead to a catastrophic wrong decision some of the time. He then went on to talk about noise, by which he means unwanted variability. That can be at an organizational level, between hospitals. It can be at a person level. You and me can have a differing view and decision on the same facts in front of us. It can even have an occasion difference. Me, on a different day, if I've had a bad night, I might make a different decision about the same set of facts in front of me as if I've had a good night. So these are all important factors that play into Mindlines, as well as Nudge and Thaler won the Nobel Prize for his work on what he called libertarian paternalism, this idea that too many choices paralyze us, whereas if you can narrow down the choices to just a few potentially good ones, you're more likely to make the right decisions. And just going back to this point about lived experience versus theory, it's what we're thinking at the time and how we have come to that decision that ultimately makes our decisions for us. In the context of sepsis, here are a few Mindlines that might cause extension of antibiotic use. Oh, broader is safer, I can de-escalate later. Duration creep is harmless. I'm more worried about recurrence, so I'll give it an extra few days. Patient's sicker than the guideline, so it's not relevant to me. Microbiology, it never comes back in time. I can't afford to wait, I'm going to carry on. This hospital's bugs are different to the guidelines, so I'm right and they're wrong. When we looked at some of the factors that might influence the decisions in our Mindlines, there were some common themes. Risk inclination. We're all risk averse, and Kahneman won his Nobel Prize for prospect theory. And really simply, all that tells us is that we value harm twice as much as we value gain. So we're much more risk averse as humans, and obviously Hippocratic Oath, that plays into that as well. External tools. Are we guided by guidelines, clinical decision support tools, point of care tests? What about our learned behaviors and preconceptions? Were we told by someone at medical school that the longer, the better? Or did we have a bad experience and we're never going to make that mistake again, right? Shared decision making. We have, I think rightly, outsourced a lot of our decision making to our micro and ID colleagues. But have we outsourced it too much? Have we given them the decisions when they don't have all of the clinical information that we're privy to? So these are some of the discussions, as well as institutional context around the decision making. As part of the Inhale study work streams that we did a few years ago, where we were looking at the BioFire PCR to try and improve appropriate antibiotic usage in ICU-acquired respiratory infection, we did a bit of this work, and in a sense, similar themes came up when we asked ICU clinicians about their prescribing perceptions and beliefs. And it was about antibiotic necessity beliefs versus antibiotic concerns beliefs. But the same things, policy and practice, our capabilities, our past experience, our environmental contacts. And it boiled down to erring on the side of caution, which tended to be the default, versus being brave and actually stopping early. Just a point now about the point of care tests for infection. Remember, I'm going to put this to you. We don't know what the ground truth is. We have indirect point of care tests, the IL-1, IL-8 that we used in VAP Rapid, or procalcitonin, which are surrogates of infection, right? But there's no bug identified. You look at the direct ones, microculture sensitivity, PCR, next generation, they have a bug, right? But we're inferring that there's an infection there. So there's no real truth here. In the end, we're having to decide what the truth is based on these surrogates of infection. When we then looked at these accurate biomarkers, and here are some examples, we looked at TREM and a number of bioscars. They had very good discriminate ability to separate VAP from a non-VAP in those patients. We then took that and the IL-1, IL-8 D-dimer concept, the idea that if it was below a certain level, there was no evidence of VAP there, so you could be confident to stop your antibiotics. And we put that to a trial of standard care versus this D-dimer IL-1, IL-8, expecting to find reduced antibiotic-free days. Of course, we didn't, and that got us thinking about what were we missing. That was an expensive negative trial. So then we sort of went on ourselves to look at the why stop set of studies. And essentially, we were asking the question, why wouldn't clinicians stop an antibiotic if all the information is telling you that you should, based on that point of care test? So we looked at vignette-based experiments, exploring behavioral factors that influence the use and the impact of a PCR-based POC in ICU-acquired HAP. We then looked at a little more detail at the value or the influence of experience, comparing clinical medical students with clinicians. And then we looked at a more realistic case of conflicting results, where we offered a slightly positive PCT result and then gave them a negative PCR result to see, in a sense, put PCT against PCR and see who came out as the winner. This was our platform. So we had 4 different common scenarios. One of patients, 1 clinical improvement and biological, i.e. lab-based improvement. 2, we had clinical and biological deterioration, where we'd expect very few people to stop antibiotics. 3 and 4 were 2 ambiguous discordant settings, clinical improvement and biological worsening, or clinical worsening with biological improvement. We've all come across those. We come across those commonly, and we're not sure what to do. So we asked the question, should you stop your antibiotics? They've had a completion course or not. And then we actually we asked them, do you want a PCR point of care test to help you with your decision? And whether they did or didn't want it, we actually gave them a result that was negative, that suggested that there was no infection there. We asked them to revise their stop or continue decisions, and we also asked them about their risk averseness. So the first study, does a negative POC result increase clinicians' inclination to stop antibiotics when they're uncertain? And clearly the answer was yes, but with the caveat that only if you decided to ask for it in the first place. So we found that about 60% of people asked for a point of care test, particularly in the ambiguous situations where they weren't sure. But it was only really those who actually were prepared to change their decision that actually increased the stop rates. What was quite interesting here, that the discordant clinically worse, but labs improving, that was where there was a lot of uncertainty. 50% of clinicians said stop, 50% said continue. But when you gave them a negative point of care test, 75% were happy to stop, and their confidence increased. So the use of point of care tests strategically when considering stop decisions could be important in this scenario. And then we asked about experience. So we pitted the clinical medical students against the experienced clinicians, and same set of questions. Initially, on the right-hand side here, which is the students, they were much more cautious. They didn't want to stop antibiotics in the majority of these scenarios. But when we asked them if they wanted a point of care test, about 60% said yes, similar to the clinicians. And interestingly, they were much more confident thereafter when the point of care test was negative. to stop antibiotics. So in a sense, this was standardized, it had a standardizing effect. It was reducing the experience gap. So just in this particular scenario, you could fast forward your further 2 years of medical school training, and you could actually make the same decisions as experienced clinicians based on a strategic use of a particular test. Just to caveat it, the third study that we did, point of care, PCR versus PCT, a few more people asked for the PCT, but actually there wasn't a positive result from that. So increasing complexity to reality actually makes it more difficult. Just a caveat as well, biomarker-guided stopping. We know that PCT has worked in adapt sepsis, in reducing antibiotic days, but it might be expensive. In the INHALE-3, although it was more appropriate use of antibiotics, actually there was a signal to worse mortality. So we need to be cautious. And the use of point-of-care tests is only useful if it's linked to a strategy of education and feedback. This is just a behavior cycle wheel from Michi at UCL. It's complex, but in a sense it gives you a framework for how you can change behavior in these settings. So in the last few minutes, I'm just going to talk about a few structural nudges that could stick and might improve antibiotic stewardship. The start smart, then focus, or otherwise known as review and revise, is well understood now. The ARC study group in the UK, about 50 hospitals or so over 3 or 4 years, actually used a multifaceted behavioral change strategy. Decision aid, training modules for safe stopping, audit and feedback, patient leaflets to reassure patients about what they were doing, and then importantly a toolkit for hospital rollouts with a local champion. And they found that over the course of 3 years, before and after, in medical patients, they were able to reduce antibiotic use by about 5 to 8% per year without any reduction in mortality. This was the decision aid. So basically, patients coming in, clinicians were asked, is this a possible infection or a probable infection? And then at 48 or 72 hours, they were then asked again, still possible? And if the indicators of improving trajectories were there, then they said, you can stop. Okay? If it was a probable infection, you'd set up whatever your timeline was of duration of antibiotics. And they found that you could increase the number of stop decisions of 72 hours, as I said, without mortality change. But the defaults are really important as well. And I mean, I'll ask you, you probably all know this on your ICU rounds, but I can guarantee that I and my colleagues don't really have this to hand when we're thinking about a VAP or we're thinking about a gram-negative bacteremia or whatever else it is. These are evidence-based studies that have shown that less is as good as more. And we heard in the last session some great talks from Hendrik and colleagues about this idea and this concept that even if less isn't more, less is not less. And what I mean by that is that there's evidence in gram-negative sepsis, in the Eurobact 2 study, in the Regard VAP study from Southeast Asia, that strategically reducing antibiotics seems not to increase mortality and does reduce antibiotic usage, with the appropriate caveats, of course, which you need to be aware about. And of course, one can use policy levers, giving the gatekeeper role to our microbiologists and ID clinicians in terms of the WHO aware strategy is really important, actually. So it doesn't allow me to put my hand in the sweetie jar and give out whatever I think I might want to do. I think that's a really important thing. And on the bottom here, the dashboard could be a really important strategy. There was some really nice work. There was an abstract this morning from Berlin where they're trying to gather the data from their electronic healthcare systems to create a responsive dashboard that would look something like this, where you would get antibiotic usage, you would look at overuse, you would look at outcomes, and you could then, with that feedback, potentially influence better antibiotic stewardship. So last couple of slides, shared strategy for antibiotic stewardship. Here are some suggestions. Co-create a policy, give your colleagues ownership, maybe invite each ward to write the first draft of a syndrome-specific duration policy. Identify champions, peer modeling. This is perfect for senior residents to actually try and take something on board and develop a strategy. Peer discussion groups, the 5-minute antibiotic timeout at the ward rounds. Just ask the question, why shouldn't we stop antibiotics? And actually then build around that so that there's shared learning. And that feedback and recognition, someone needs to be able to show you some graphics that says, you overused antibiotics, I'm not making a judgment on why you did that, but you did overuse them, so have a think about them. And of course, the defaults on your electronic health record systems, which would be really easy to do. Just set a 72-hour or 3-day alert. This is I took from the last session, which was just a wonderful idea from the professor from Sheba Medical Center in Israel. Just the concept of, for the incentivists, talking about these aspects, for the microbiologists, joining the bedside discussions, for the referring physicians, interact not just on the clinical matters, but actually on the microbiology as well. So here's the 5-point playbook and call to action, if you like. We've talked a little bit about Mindlines and heuristics and how those can influence the decisions we make, particularly if there isn't a set rule to stop. We've talked about defaults. We've talked about strategic use of point-of-care tests to help you if you're equivocal about whether or not you should stop. The importance of dashboards, and that'll take a lot of work with the EHR systems to develop. But the education and training can start right now at the bedside, just asking why shouldn't we be stopping antibiotics? What's the syndromic duration that is evidence-based? Are there any caveats that would prevent us from doing that? So we could maybe change the conversation, and the mantra could become broad start, early stop, and the idea that that could become safe, normal, and expected, I think is something that we can aspire to. I'm going to stop there. Thank you very much.
Thank you, Suveer. Impressive talk. Are there any questions from the audience? If then please use the microphone, please.
I'm from India, Dr. Bandyopadhyay. Basically, the problem of stopping antibiotics, convincing, not telling, stopping, convincing the associate physician to stop the antibiotic is that once we use this point-of-care test, we use them, PCR, but in ICU, particularly for ventilator-acquired pneumonia, we seldom get a test which is absolute zero. It's not like you grow something. Maybe the copy counts are not significant, but then grow. Then people, they go on arguing that you have already given antibiotics, the copies may not be going to the standards. And also there are papers, I think, which have shown that say copy of 10 to the power 5 does not exclude the infection. There is less chance of infection, but you cannot exclude actually. So that is the point of making a choice. And about the duration, even Shastra's original trial of, they excluded the resistant jumps. I think the Pseudomonas was excluded. Yeah. So we are, basically, when we have hospital-acquired infections, they're just resistant germs. Yes. So again, unless you have got a clinical as well as, bacteriological cure, it is very difficult to convince that the patient is really out of danger. Would you like to comment on that?
Yes, no, thank you. My relief slide was talking about, I don't like the term global north and global south, but it was high income versus low and middle income countries. And in the high income countries, we're subjected to overuse because it's too easy. In In the low-income countries, there are much more important factors that need to be tackled. You know, the lack of diagnostics, the uncertainty there, the complexity of multi-resistant organisms. So absolutely, I think that needs to be adapted. But the principles of developing a policy in your own institution and understanding what the feedbacks are could help to improve things. So absolutely, it's a good point made that's recognized.
Yes.
There's another question.
Yes, Professor Bassem Boulis, intensive care from Egypt. Actually speaking, I have a comment and a question. The comment is the real-life situation showed that the mindset of the junior staff is to start antibiotic early and to stop late.
Yes.
And the mindset of the most senior staff is to start late and stop early. But actually speaking, the modest is every minute count. So we have to change the mindset of either the senior staff and the junior staff. This is the comment. The question is, the real life situation is in many times showing in my ICU that the point of care and the tests, whatever we are doing, many times in septic patients goes in a way different than the clinical. We find that the patient is improved clinically, and in spite of that, the PCT is still high and the CRP is still high. So the controversies among us was to stop the antibiotic according to the clinical situation or to continue giving according to the point of care. I need your opinion in that.
Yes, and that's why we did the why stop studies, that ambiguity. And we did it specifically when the PCR was negative or the PCT was negative, because in the end, that is going to, if you're using that as the arbiter of your decision, you have to judge on that. But generally speaking, in medicine, going back to Osler's time, you know, where clinical medicine was trumped lab medicine, and then he brought them together. It's still clinical medicine and your clinical beliefs that ultimately are the ones that you tend to go on when there is a decision to make and you don't have anything else to do it. Now, I think that's a difficult situation where where there is a high stake involved, and you might decide to extend as a result of something. But you need to keep asking yourself, what's the next point at which I can make the decision in the favor of stopping? What is it going to be that's going to help me to make that decision? I think that is probably the learning from this. How do you then say, okay, we'll carry on for a bit further, but my default is going to be stop unless something else happens. So I think that's the way that you can build in the learning to that.
Okay, I have one question to the professor, because we talking about the change the behavior, and it's really important. And did in London, in Great Britain, for example, you prepare some ID consultant 24 hours to help the clinicians to interpret the results? Because in my country, the most problem is to, make the decision. And if the doctors have someone who help them, it is really better decision. Do you have this?
I think that's a really important point. I mean, in a sense, what I've really been showing you with the point of care tests is the decision maker, right? We've just given it an intangible decision maker, a non-human decision maker, being that point of care test. So absolutely, and I think it's important that we somehow do the shared learning, re-educate ourselves about the importance of these things. It may well be, but it differs, that we don't teach this well enough in our clinical practice because it's a complicated system, right? But I think there's probably a lot to be gained. And I think, if you went to the last session, you saw a huge amount of this idea of less is not less. And I think as more of that comes out, it's not going to change practice unless we actually start to believe in it and use the tools I've been suggesting to actually push that forward. In a sense, we're going to have to be a bit braver based on the evidence and I think then implement that.
Thank you for the excellent talk, and I would. And I would like to introduce the next speaker. It's Professor Maddalena Giannella from Bologna in Italy. Professor will tell us a few things about the rapid diagnostic in the ICU and challenging misconception to drive better antibiotic decision.
Thank you. I would like to thank the organizer of the symposium for inviting me to give this presentation. These are my conflicts of interest, and this is the outline of my talk. I will review the clinical value of multi-loop PCR in ICU patient and barriers to full use of multi-loop PCR, in particular in bacteremia and lower respiratory tract infection, and I will give you some special consideration about the use of this tool in immunocompromised host. As for the clinical value, this is multi-loop PCR are considered a good tool to optimize antimicrobial treatment in critically ill patients. As already stated from Professor Singh, starting empirical treatment in critically ill patients should be based on 3 factors. First of all, certainty of diagnosis, risk of the line treatments, and last but not least, we have to consider the environmental damage correlated with antibiotic misuse. So current guidelines emphasize these 2 decision-making factors. From one side, bacterial in the certainty of bacterial infection, and from other side, illness severity. In patients at high risk of death, with high risk of death, or when the suspicion of bacterial infection is very high, we have to start antibiotics immediately. In the other cases, we may have a 3-hour diagnostic window to improve and to avoid overtreatment, so to improve antibiotic use. And in these frameworks, the advanced diagnostic, among them multiple PCR, are considered very useful to reduce the time to diagnosis and optimal therapy. This is, in this table, there is an overview of the main rapid diagnostic tests available for the diagnosis of bacteremia, just to underline the rapid turnaround time and high sensitivity and specificity. Then I will remark that the majority of these tests are able to detect a predefined number of bacterial and fungi and a predefined set of resistant mechanisms. This is the same for rapid diagnostic tests to identify causal pathogens of pneumonia. Some of them include several respiratory viruses and intracellular bacterial, other also pyogenic bacterial with resistant mechanism. Again, rapid turnaround time, high sensitivity and specificity. So considering these characteristics of the test, high sensitivity, this has improved the rate of patients with an etiological diagnosis, mainly for lower respiratory tract infection, where usually the diagnostic, the etiological diagnosis may be reached in 40%. With the use of this test, we may have an etiological diagnosis, we may achieve an etiological diagnosis in more than 70%. But at the same time, there is the problem of over-detection. Sometimes it's difficult to differentiate between colonizer and infective pathogens, but here the solution is to select the patient, the right patient for the right test for the right patient. So pre-test probability, the assessment of pre-test probability is very important. For high specificity, if we have a negative test for a pathogen present, included in the panel, the high negative predictive value is, can be relied. We can exclude the presence of that pathogens. However, we have to keep in mind the problem of off-target pathogens and resistant genes, and this could be more common in immunocompromised patients. So for this problem, we need to realize to use this test in parallel with the conventional cultures. Rapid turnaround time, of course, is very important to achieve rapidly the etiological diagnosis and to improve antimicrobial treatment. We may have lack of trust, but the solution is already being addressed, is to have a predefined workflow, to have a plan, to establish whom will interpret the results and whom will be in charge of translating the results in therapeutic recommendation. As for antimicrobial resistance, just to remark that when we use molecular tests able to provide genotype resistant determinants, genotype resistant, we can rely on this test for both de-escalation and escalation for gram-positive, because in gram-positive there is a good correlation between genotype resistant mechanism and final phenotype. But this is not the same for gram-negative, because in gram-negative we may have several mechanisms of resistance, not only enzymatic mechanism. So we may rely on this test for escalation when a mechanism of resistance is detected and my initial treatment is not covering that mechanism, but for the escalation we have to be very careful. This is the classical example is Pseudomonas aeruginosa, where we may have several mechanisms of resistance, but there are also some problems. This is an example from Italy. These are 2 cases of sepsis with molecular identification of a Klebsiella pneumonia group on blood cultures, and the same genetic antibiogram, a strain producing KPC. However, in one case, we have standard antibiogram with the strains susceptible to ceftazidime avibactam, meropenem vavorbactam, imipenem lebactam, and cefiderocol, as expected. But in the second case, this is a KPC variant, is an emergent problem in my countries, where the strain is resistant to ceftazidime avibactam and cefiderocol. So we are very interested in having a rapid phenotype test able to provide in few hours, 6-7 hours, the phenotype, the final MIC. These tests have been introducing in our clinical practice. Clinical studies are still preliminary, so we need more data about cost-benefit analysis. We have, for some of them, started from molecular identification. We may have still problem with the off-target pathogens, and novel antimicrobial may not be included very soon in this panel. Then the other problem are polymicrobial infection. These tests are more difficult to interpret when there is a polymicrobial infection. Which is the evidence from the literature about the impact of rapid diagnostic tests in bacteremia? In this systematic review and meta-analysis, the authors addressed the issue if the use of molecular tests may have an impact on mortality, time to effective therapy, and length of stay compared with conventional cultures for bacteremia. They included 31 studies, more than 5,000 patients, and they conclude that the test has an impact, a positive impact in reducing mortality, but this impact is significant only when this test is embedded with an antimicrobial stewardship program. And so what about, which is the added value of the test on an antimicrobial stewardship program compared with the stewardship program with conventional cultures? This issue was addressed by this systematic review and network meta-analysis, where the authors, including more than 88 studies, more than 25 patients, concluded that rapid diagnostic test plus stewardship is superior of stewardship plus conventional blood cultures in both reducing the mortality risk and the time to optimal therapy. So, but which are the implications of this kind of approach in our clinical practice? This is an old study, but it's a very nice example. In this study, the authors compared three periods. In the first period, there were not rapid diagnostic tests and not a dedicated stewardship, a stewardship program dedicated to bacteremia. There was a standard stewardship program in the hospital. In the second period, they introduced the rapid diagnostic test, and in the third period, they also introduced a stewardship program dedicated to bacteremia, to the interpretation of the test to give therapeutic recommendation for the prescribing. And how they work. The rapid diagnostic test was available 24 hours per day, 7 days per week. The stewardship team was available during working days, working hours. For the rest of the week, they created a reference treatment algorithm. With this approach, They observe, along the study period, a progressive increase in ID consultation activity. The ID consultant participated in the stewardship program. There was an increase in the use of optimal therapy, optimal defined as active with a narrow spectrum, and a progressive decrease in all-cause mortality rates. About therapeutic algorithm based on genotype resistance, just to mention that it could be almost easy to create this kind of algorithm for gram-positive because, as I already said, genotype-resistant determinants are there is a good correlation with the final phenotype. However, in the case of gram-negative, these therapeutic algorithms are much more complicated because we may have different kind of pathogens with different kind of resistant determinants. Some of them usually are included, the majority are included in the panel, other not. And we have also to consider the access to the new drugs, so not easy exercise. As for the phenotype, this is a recent report on a preliminary experience with the use of one of the phenotype rapid tests available on a cohort of patients, critically ill patients with gram-negative bacteremia. The author showed that during the prospective phase, when 50 patients were 50 patients, the rapid test was prospectively done. Compared with the retrospective group of patients, there was a reduction in the time from positive blood cultures to antimicrobial susceptibility testing results, phenotype test, 24 hours versus 11 hours, and this had an impact on improving antibiotic optimization within 24 hours. However, we know that this test may be have a cost, and I think that a very good way to use to select patients where this test may be more cost-benefit is to use artificial intelligence models. We try to create a model using our dataset of patients with gram-negative bacteremia, more than 2,000 bacteremia. We developed the model to be able to predict the resistance to carbapenems, fluoroquinolones, piperacillin tazobactam, and third-generation cephalosporin, using very easy to collect variables, easy to collect from electronic health records, and starting from the species, at the species level. This kind of tool may improve our current approach from a completely empirical, reasoned treatment to a personalized treatment, because they making us able to select the right patient and to select the right test. What about lower respiratory tract infection, which is the clinical utility of syndromic molecular diagnostics in critically ill patients with pneumonia? This question was addressed in this systematic review, including 5 randomized controlled trials, more than 2,000 patients. The author showed that the use of this test had not, in the study, had not impact on in-hospital mortality. However, they improve the rate of adequacy of initial antimicrobial therapy compared with standard cultures, as well as reduce the time to effective antimicrobial therapy. These are the trials included in this systematic review. There are some differences between them. I will give you detail just from 3 of them. The first one from UK, the authors used the test as a molecular, as a point of care test. So the access to the results was very fast, 1 hour, 0.7. And with this approach, they achieve the result-directed therapy in 80% of patients in the control arm, in the intervention arm, compared with 29% in the control arm. And the time to result-directed therapy was 2.3 hours. So this type of results fits very well with the need of being in a 3-hour diagnostic window to improve our certainty of bacterial infection and antibiotic use. The second one from US, this is a very large trial, single center but very large, including more than 1,000 patients, However, just half of the included patients had pneumonia. Why? Because in this trial, the use of multiplex PCR was randomized in the lab. They selected appropriate sample, sputum, endotracheal aspirate, and BAL, and randomized the sample to receive molecular test plus conventional cultures or culture alone. And then they published the results on the antimicrobial stewardship page. Antimicrobial stewardship team was available during working day, working hours, and when they acquired the results, they review the electronic health record of the patient to provide therapeutic recommendation. With this approach, there was not a strong impact on the time to optimal therapy. In addition, there was also a significant increase of potential colonizer detection from the multiplex PCR compared with conventional cultures. However, in the pneumonia cohort, there was still a benefit in terms of the escalation of gram-positive antibiotics in in those using the multiplex PCR in the intervention group. And then the INA trials are already anticipated. In this trial, the authors used the molecular PCR as a point of care. It was the test was performed in ICU, so the results was immediately available. And the ICU team had access to a localized antibiotic prescribing algorithm, translating the results to prescription advice. There were two co-primary endpoints. The first one, superiority in stewardship, defined as proportion of patients on appropriate and proportionate antibiotics within 24 hours. And the second one, non-inferiority in clinical cure, defined as absence of death related to pneumonia, septic shock related to pneumonia, relapse or pneumonia, or other evidence that the pneumonia was not cured. To 2 weeks. There was the achievement of primary endpoint with a clear superiority of the multiple PCR in reaching appropriate and proportional antibiotics within 24 hours. However, non-inferiority for clinical cure was not demonstrated because there was a lower rate of clinical cure in the intervention compared with standard of care in both intention to treat and per protocol analysis. And curiously, there was also a trend for mortality, and curiously, this reduced clinical cure was observed in a sub-analysis just in those patients in which stewardship was achieved, but not in patients in which stewardship was not achieved. Going to last part, a few words about immunocompromised host. In immunocompromised host, we have less evidence, but surprisingly, according with this pre-consensus survey performed from the American Society of Transplantation, they asked about the use and the impact of the use of the advanced diagnostic tests on the management of the antimicrobial treatment. A multiplex PCR were very frequently reported as frequently used, more than expanded antimicrobial susceptibility testing for new antimicrobials, with frequently they changed the management of antibiotic treatment. The authors recommend to consider this test additive rather than substitute of conventional methods, in particular for gram-negative bacteremia for the problem I already said of off-panel bacterial and resistant genes. They mentioned a very low series of patients underwent bone marrow transplantation with the bacteremia, where using one panel there were relatively high rates of target pathogens, so they invite to have more study dedicated to this setting to assess performance and reproducibility, clinical impact, and cost effectiveness. We presented last year our analysis on this point about high rate of off-target pathogens, mainly in hematological patients, potential high rate overestimation of resistance mainly in colonized patients, but overall the test was very useful to reach definitive diagnosis. So my take-home message are that these tests can accelerate appropriate antibiotic therapy and support precision management in critically ill patients. However, their clinical values depend on the context, so patient characteristic, pre-test probability, type of samples, and timely integration into a clinical decision making are very important. So speed alone is not enough. We have, as I already said, aimed the use of this test in antimicrobial stewardship, and real-time communication between the lab and clinician is very important. We need more data in immunocompromised and transplant population. And between future priorities, integration of this test with the AI decision tool could be very useful to improve the use of diagnostic resource, use of antimicrobial, and the clinical outcome of our patient. Thank you.